The only response that I was personally given was just, I hit him, oh my God, I hit him.
And when she's saying, I hit him, oh my God, I hit him, how loudly is she saying that?
So she was within 2 feet of me, but very loud. Any type of follow-up questioning, did you hit him with your hand? Did you kick him? What happened? She just repeated the phrase over and over again, I hit him, I hit him.
And just to be clear, where does this conversation occur?
This was as we're bringing equipment over to the patient. The interventions are going to be started basically by whoever gets over to the scene first. I'm trying to gather information as a lead paramedic to try and coordinate interventions and therapy to kind of holistically be the team leader in that situation and treat and transport the patient. So it was on approach to the patient, probably halfway between the ambulance and the patient.
And with regard to that treatment of Mr. O'Keefe, I think you referenced it earlier being within your report. What were sort of those steps or what, if anything, did you and the other firefighters do with regard to treatment? Before you answer that, Your Honor, may I request, may the witness just refer to the ZMS report as he goes?
Yes, if need be.
Thank you. So we try and document through our flow chart of all of the interventions that we're doing. So CPR is obviously going to be our first priority. CPR is initiated, unchanged but successful in the actual intervention itself, no complications. We do our ALS assessment that we talked about of any further indications of this is not a viable arrest. We determined it was a viable arrest and we move on. Then we're going to start, we refer to it as a bag valve mask at 15 liters per minute on oxygen. The patient's not breathing on their own, so we're trying to assist ventilating that with high flow oxygen as well. And easy IO, which is a needle we put into the bone of the tibia of the patient. That was on the right tibia was the first one we put in. We're going to be putting in warm fluid. We have a warmer in the back to be able to bring up the core temperature. Then we start with epinephrine, 1 milligram through that IO.
If I could just stop you there for 1 second. When you say as far as IO, put it into the leg, how is that sort of inserted into the leg?
So we have two different methods we can do. We have a drill, a power drill that drills through the outer layer of the bone into the capillary area of the bone, the soft, spongy material. So we drill through that, or we can do it by hand if that fails.
And when it comes to the epinephrine, what is sort of the purpose of that medication? What are you trying to do with that medication?
So that medication will improve, it's a vasoconstrictor. It'll cause the vasculature to constrict. So it'll improve the quality or effectiveness on the cardiac muscle, cardiac vasculature, and the cerebral area.
So as far as the administration of epinephrine is concerned, is that something that's done once or more than once? And is there a protocol for that?
So it's going to be serial every 3 to 5 minutes during the cardiac arrest to try and bring them over to the hospital so it continues that entire time unless there's a rhythm change or that can change our algorithm of how we approach the patient, if there's a rhythm regain or return of spontaneous circulation.
And so how many times or what times was the epinephrine administered via the IO to Mr. O'Keefe?
So I have epinephrine at 620, 625, 630, 635, 640, 645.
And when was that first administered? Would that have been at some point when he was outside of the ambulance on the ground or in the ambulance or something else?
It would be dependent on transport time. So we're at patient side at 6:15, transport 6:27. So best estimation would have been inside of the ambulance at that point.
I'm sorry I interrupted you before, but after sort of the introduction of the epinephrine, what if anything, did you and the other firefighter?
After the first round? Yeah. So first round of epinephrine. After that, we would drop in what's called an OPA. That would be to push the tongue out of the way, open up the airway to improve our bag valve mass so it has an open air way to get the oxygen into the lungs. We begin external warming, stripping the patient, getting the heat turned up in the back of the ambulance. We would then switch over from manual CPR done by hand to a mechanical CPR device to ensure adequate, consistent CPR compressions of the chest. It was a Lucas device. Put that on the patient. And then we continue with another round of epi. Patient's starting to warm up this time, so we would do suction at that point to try and suction fluid out of the airway to improve ventilation efforts. Another round of epi is done. We have another suction, this time through a deep suction via the endotracheal tube. Oops, sorry. At 6:22, after warming, we intubated the patient. We have a 7.5 tube paced at 27 centimeters, and then verified through various means, through chest rise, auscultation, waveform, and tidal CO2. So we had complications listed as patient vomiting, aspirating. Suction was then done with a rigid tip suction device. After successful intubation, we then suctioned via French tube through the airway established. Jump back up to 6:31. Another IO line was established on the opposite tibia on the left side. And then another 3 rounds of epi, and then arrival at the hospital.
What was the arrival time at the hospital?
At destination was 6:45.
What hospital was that again? I'm sorry.
Good Samaritan Medical Center.
There's a term that you use in your reports called, and I'll probably butcher this, but asystole, is that correct?
Yeah, asystole is going to be a cardiac rhythm where there is no electrical activity in the heart and is referred to as flatline.
What, if any, observations did you make in your treatment diagnosis in regards to Mr. O'Keefe as far as asystole?
So that was the rhythm he was found in. From initial rhythm I have on the EKG at 6:32 is asystole. So we'd basically observe that for any changes, whether it's increase of electrical activity, regain of adequate pulses, all of that can kind of be hinted at with the cardiac rhythm. And then we would change our algorithm based on whether we go down the ROSC protocol or we continue down the cardiac arrest protocol.
And whether it's on scene or it's in the ambulance, is there sort of a division of task or a division of different skill that's being employed in patient care?
So patient care will have to do with level of training and also proximity on the patient. Where you get into the ambulance is just logistically, if you have the training, it's not a huge open ER, it's a small environment. So we try and not have people jump over each other as best as we can.
And if you recall, who was sort of doing what in relation to treatment of this patient?
So in the back of the ambulance specifically?
Yes.
Okay, in the back of the ambulance, Tim Nuttall was managing the airway. I was the team lead that was kind of coordinating all of the interventions. Matt Kelly was assisting in gathering equipment, doing CPR before the mechanical device was placed on. Basically, they act as an assistant to hand equipment, place things in strategic areas around so we can actually work without having to go get those physical things ourselves.
Now, as far as you indicated removal of Mr. O'Keefe's clothing once in the ambulance, correct?
Yes.
What was it about sort of the condition of the clothing that led to the removal of that?
So removal of clothing is actually pretty standard for any cardiac arrest, any traumatic injuries. We're basically trying to get further clues because this is all happening very quickly. So we're trying to get more evidence of why are they here. We're looking for extremity injuries, crush injuries, bruising, anything that we could document, that we could pass on to the emergency room staff and doctors. So we would strip most patients.
And as far as, were you involved personally as far as sort of the cutting of the clothing and stripping the patient?
Yes.
And upon removal of the clothing, what, if anything, did you observe as to sort of the condition of the clothing or texture of the clothing at that point?
Condition seemed pretty well intact, but just wet and cold.
And what, if any, relationship would the wet and cold clothing have to any of the diagnoses that you were running through in regard to Mr. O'Keefe?
It would really just be the exposure to the weather would be our biggest trigger off of that, or if you had protruding injuries through the clothing, compound fractures, things like that. The clothing was intact, but we knew it was wet, it was cold. So as we strip things off of him, we can see underneath basically if there are any not every fracture breaks through the skin, not everything causes obvious things, obvious signs. So as we strip the patient, we can begin to further assess.
Take you back just for a second to outside of the ambulance.
Yep.
What, if anything, specifically were you able to observe with reference to any injuries Mr. O'Keefe had sustained?
Injuries are pretty tough to see outside of the ambulance just due to the weather, due to the lighting. We have seen lighting on the ambulance as well, but
Let me ask you
Yeah.
this, as far as what, if any, difference did you know between the lighting in the back of the ambulance versus when you were with Mr. O'Keefe on the ground?
so he was still out in the weather at that point, so bleeding wasn't really obvious at that point. As soon as we get him into the back of the ambulance, then we start noticing hemorrhage from different areas of his body.
And when you say hemorrhage from different areas, which areas specifically?
So mostly from his mouth, his eyes, nose. Yeah.
And just to be clear for the record, when you use the term hemorrhage based on your training experience, what do you understand that?
Bleeding, external bleeding.
Now, you mentioned that there was some suctioning of Mr. O'Keefe's airway, is that correct?
Correct.
And what, if anything, specifically was suctioned from Mr. O'Keefe's airway?
Suctioning from the airway was mostly blood, sputum.
And as far as how much, what, if anything, you have to sort of measure how much blood was suctioned out of Mr. O'Keefe's airway?
So we have a canister that has marks of milliliters, so we can determine as we're suctioning how much is in that container at different times.
And about how much, based on that, was suctioned from Mr. O'Keefe's airway?
So the initial suctioning with the rigid tip was about 150 milliliters. And subsequently, so that would have been above the airway, in the mouth, in that type of area. We established the intubation, and then deep suctioning with that soft tip through the intubation tube would have been another 50 milliliters of fluid.